Hello, everyone. This is Robert Miller, Executive Director at the National Fragile X Foundation, and I'm welcoming you to one in a long series of National Fragile X Foundation webinars, Let's Talk webinars, and today it's our great honor and privilege to have Dr. Craig Erickson speak to us about medication for Fragile X syndrome. Dr. Erickson, who I'm known for many years, a wonderful and very knowledgeable doctor, very caring individual, is the director of the Fragile X Research and Treatment Center and an assistant professor of psychiatry at Cincinnati Children's Hospital Medical Center. So, Dr. Erickson, it's just an honor and a privilege to have you here today. Before you begin this evening's presentation, I want to thank Warren Global Conferencing for making this webinar possible. And I also want to apologize for those of you who joined us at the last attempt to hold this webinar. We had technical difficulties and had to reschedule. So I think things are going smoothly tonight. We're looking forward to a great presentation. So without further ado, as they say, I'm going to welcome you, Dr. Erickson, and let you begin your presentation.
Thank you, Robbie. This is a great opportunity. I really appreciate the chance to do this, and I think this is an important time in the Fragile X community to talk about medication, and I think we'll address a number of important issues. Unfortunately, my webcam is not working, but I hope my audio is, and I'm just going to start by going through a brief set of slides that provides a little bit of an overview thinking about medications, and then really want to spend the vast majority of our time taking direct questions from participants. So with no further ado, we'll go to the next slide. And my first slide is just really all of my potential conflicts of interest, and it's funding that we get for research at Cincinnati Children's Hospital. There's a number of foundations and pharmaceutical companies, and we participate in a lot of investigational medication studies in Fragile X, both when I was at Indiana University and then most recently for the last year at Cincinnati Children's Hospital. So I always want to be forthright about where we get support from. So now the next slide really provides an initial overview of targets of medication, and this comes from some really solid survey data from Don Bailey's group in North Carolina that looked at targets of treatment of medication, and I like to think that there's some time association with earlier in life significant concerns at times of inattention and hyperactivity, maybe around school age onset, significant concerns for anxiety. And then if individuals are going to exhibit irritability like self-injury and aggression, tends to come on more during adolescence and can be a potential target of treatment. So these are some targets to keep in mind for sort of off-the-shelf medication treatment. And I think this evening we can discuss a medication in a broad sense, both using things that are already available to treat symptoms and behaviors that occur in some people with Fragile X syndrome, and then I'm happy to also address more sort of targeted investigational treatment. So this slide just helps frame, I think, some of the potential symptoms that families have reported in the past that may be a target of treatment in both males and females with full mutation Fragile X. All right, our next slide. This slide talks a bit about available medicines that are out there. So when we think about attention and hyperactivity, I think some of the most commonly used medications are stimulants, which include things like Ritalin and Adderall. Also commonly used in Fragile X syndrome are medicines called alpha-2 agonists, which are traditional blood pressure medicines that have recently also been FDA approved to treat ADHD symptoms, and those names include 10X, which the generic is guanfacine, and clonidine. And then another medicine used for inattention or attentional problems and hyperactivity at times is called atomoxetine or Strattera, and it's FDA approved to treat ADHD and is used to some degree in individuals impacted by Fragile X syndrome. Again, these are all sort of commercially available. Physicians can prescribe them now, medicines. For anxiety, I think the mainstay of treatment is still the SSRIs, which are selective serotonin reuptake inhibitors. They're very commonly used in individuals with Fragile X. There's been limited research, really. Randy Hagerman's group many years ago now published some data on SSRIs, but they're commonly used, and some of the names maybe Celexa, Lexapro, Prozac, Paxil, Zoloft. Buspirone is a medicine that's FDA approved to treat generalized anxiety disorder in adults, is sometimes used. It has an effect on serotonin receptors, but it's not a SSRI. And then the benzodiazepines, which are FDA approved to treat anxiety, but sometimes are less often used because of potential concerns about the effects wearing off in time and potentially having a dulling effect on thinking, but they do have some role. Ativan, Klonopin, Xanax, Valium would be examples of those. As far as treating self-injury and aggressiveness or irritability and agitation, newer generation antipsychotics like Abilify and Risperdal, which have FDA approvals in autism, are often employed. At times, mood stabilizers, which tend to be historically FDA approved to treat things like bipolar disorder, may have some benefit in some individuals for self-injury and aggression, and medicines like that are include lithium and Depakote. And lithium sort of crosses over as a potential targeted novel Fragile X treatment, and I'm happy to speak more to that. And then the next slide really looks at what's more been looked at in these sort of novel treatment areas. So after this slide, our next one talks about, well, what are some potential targeted Fragile X specific treatments? Let's flip one side back. There we go. And this includes medicines that are FDA approved for other things that are being have been and are currently sort of experimentally studied in Fragile X. And going back to the first real medicine, folic acid, which was studied in the 1980s based upon the concept that, the term Fragile X refers to a chromosome fracturing in growth media that did not have folic acid in it. So the theory was to treat with folic acid. Unfortunately, those were not positive studies. But that's really the first targeted treatment that's been studied, many since then. And the column on the left, beginning with folic acid, are drugs that are repurposed or available for something else. So lithium, again, is available for bipolar disorder. Minocycline is a medication for acne. We've done some research with a drug called Riluzole, which is approved to treat Lou Gehrig's disease. Memantine is a medication that treats dementia. In Cincinnati, we do significant research with a medicine called acamprosate, which is approved for alcoholism. Donepezil treats dementia, and then lovastatin treats high cholesterol. So those are all, and that's just some of them that are out there, but it's really a rich field of new potential treatments. And then on the other side, ganaxolone, phenibom, the various lettered drugs that are investigational and experimental, including STX-209, which has been the topic of great recent conversation, and oxytocin. These are things that are not FDA generally approved, that meaning a physician cannot just prescribe them. They're all being researched for many of them for varying conditions, including Fragile X syndrome, and some of them just really for Fragile X syndrome. So those are more experimental drugs, and we differentiate those from the other class that are just being repurposed potentially for use in Fragile X syndrome. So that's a little of the background. I don't want to use up any more time. I think if you can just put up my last slide, that's my contact information, and I'm happy offline to be contacted and continue a dialogue and be able to assist in any way possible. So again, I appreciate this opportunity, and I look forward to answering questions the rest of our time together tonight.
Thanks, Dr. Erickson. Can those whose questions do not get answered tonight then go ahead and directly contact you with that email?
Absolutely.
Okay. Dr. Erickson, as you alluded to in your comments already, there's been quite a bit in the news recently about arbaclofen or STX-209, an experimental drug being studied by Seaside Therapeutics, and the recent news that they were ending an extension of that, and some study results that didn't quite turn out the way I think that people were hoping. Could you say a little bit about, first of all, what your role, if any, has been with arbaclofen and your observations and comments?
Sure. So I've known the individuals associated with Seaside Therapeutics going back many years, and we have, when I was at Indiana University, enrolled adults with full mutation Fragile X syndrome in what was really the first STX-209 study in Fragile X. And since then, we have enrolled participants when I was at Indiana University in the subsequent studies. I have not been directly involved in any of the open label extensions, and that's really been in part because the extensions started around the time when I made my move from Indianapolis to Cincinnati, Ohio. So I have a lot of knowledge of the STX-209 clinical trials and the drug development process. And, you know, I would say by background, STX-209 is a medication that is really a derivative of a otherwise available drug called baclofen. It's sort of, in my mind, purified baclofen, or it's the active ingredient in baclofen. And it was studied based upon some preclinical or animal evidence that it may be of use in Fragile X syndrome and autism of unknown cause, for that matter. And, you know, Seaside Therapeutics is, as a company, dedicated really themselves to development of medications for neurodevelopmental disorders. And, you know, I think there really is, there's a twofold issue here. One is the open label extension was discontinued, and I'm happy to give some thoughts about that. And the second issue is that they've stated that at least their trial in older individuals essentially had a negative result or did not show improvement greater than a placebo sugar pill, which at this stage of the game, for medication development, whether it's being developed in Fragile X or any other disorder, tends to lead to you know, discontinuation potentially of development of the medicine, which I think is obviously very concerning for those that had perceived in real benefit from it. The open label extension phase, you know, first of all, I think individuals should realize that Seaside Therapeutics and any company are not under mandates, governmentally or otherwise, to offer open label extensions. And I have to really commend Seaside Therapeutics and other companies for doing this, because they are very costly. And they are really done, I think, in all cases, to benefit patients and individuals as much as possible, in a sense as a reward for participating in a placebo-controlled trial, that someone would have the opportunity to get an active investigational medicine for an indeterminate amount of time. And what I think what's happened with the STX-209 case is really, you know, the most unfortunate circumstance where out of this setting of a willingness to provide ongoing care at a great expense, the care went away essentially for financial reasons, which are clearly based in the otherwise negative trial results. Meaning that if the placebo-controlled trial would have a positive result, I think undoubtedly financially viability would have been there to continue the open label extension. So, you know, there's no one out there making a choice to take away treatment for any other reason than really feasibility isn't there. And I can say that with some certainty. So I think it is incredibly unfortunate I think that I am sure that there are individuals that benefited from this treatment. I think the problem in the placebo-controlled trial was that the percentage of individuals that showed benefit when they didn't know if they were on the drug or placebo was not sufficiently greater than the percentage of individuals that had benefit getting the placebo sugar pill. And that's really what the United States Food and Drug Administration and regulatory agencies around the world that regulate prescription medicines require for approval. And so it does not appear, at least in the older individual study, that it's met that. Now, I know the results have not been announced from the younger child study. So, I think we should all have some degree of hope that that could be a different result. And if that were to be a different result, that could still move forward STX-209. So I don't think that anyone can say that it's going away, certainly, but it is concerning what's happened. And I'm happy to address, and I've been asked to address by many families who are in the open label extensions, what do we do now? And I think that, among other points, are sort of the next steps to try to provide the best options. But it's an unfortunate situation. There's certainly no malicious intent from anyone involved. And I think we just have to work as a community, both a clinical provider community and in a research community, to do the best we can given what's happened.
All right. Thanks very much. I really appreciate your openness and willingness to tackle that difficult subject. So, Dr. Erickson, I'm going to read you some questions that have come in here to the Foundation. I'm going to start with some of the more general questions, and then I will read those questions. Okay. So, Dr. Erickson, I'm going to start with some very general, generic questions. Because of time, I know that you're not going to be able to go into tremendous detail. I think some of these questions are so complicated that we could spend the remaining time just answering one question. So I'll leave it you to make the judgment on how detailed you want to get in your reply. But one of the first questions I think is a great question. It's not about a medication specifically. It's a question that says, is there a medication now in clinical trials that will reverse Fragile X syndrome? I heard that in mice it was reversed.
There is, of all the medications that have been studied in Fragile X syndrome, I would say that nothing has been shown to definitively reverse aspects of Fragile X. And, I think the term reverse Fragile X is tricky in humans because in animals, it refers to things like looking at brain cells that then grow normally, and looking at exposing animals to really loud noises and they normally have seizures and then they don't feed. I think the reversing in the animals shows hints that a medication may provide some success in humans, but we're not sure what that success may be, and we're also not sure what that success may look like in different ages. So when I think of a successful treatment in Fragile X, I think of something that at a minimum provides some significant symptomatic relief, whether it's reduction in any of the domains I talked about earlier. And then secondly, what we would be hopeful for, but I don't think is a requirement for successful treatment, would be if a medication could alter or improve the developmental trajectory or one's ability to learn and make gains. So I think thinking of reversing Fragile X in the sense of it completely going away is ideal. We all work towards it, but I don't think that that's necessarily what we should define as a potentially successful treatment. And none of these investigational medicines, including the ones I study, and I study primarily now acamprosate, have been shown to essentially make Fragile X go away in that sense of reversing.
Right. Okay, thank you. Thank you very much. Here's again another less general question, but not a medication-specific question. This is from Gina, who says, my problem is with my 9-year-old son with Fragile X syndrome, PDD-NOS, with a mosaic full mutation who is nonverbal, but with academic strengths. He can read, and he understands directions, for example. She says she's at a point now where he is on nothing since early May so that the doctor could get a baseline. The prescribing psychiatrist isn't very familiar with Fragile X syndrome, so she's hesitate in trying anything. What would you say to that question? How would you advise her to move forward?
Well, the first thing I would do is, if you're in a setting where somebody does not have significant Fragile X syndrome experience, I think your safest course of action is to extrapolate from the research data and things available in other disorders, meaning if an individual off medication is having significant hyperactivity or significant inattention that's impairing their ability to learn, really a first step trying medicines that are tried and true for ADHD symptoms even outside of Fragile X, like stimulants or the alpha-2 agonist I mentioned in my slide, I think really makes some initial sense before getting really novel onto that sort of ladder slide with more investigational approaches. The same way if somebody was really obviously exhibiting a lot of anxiety that was impairing, something like an SSRI trial I think would be logical and could be started, we would recommend at a conservative lower dose. And then finally, if you're in a situation like that where the primary target is a significant self-injury or aggression that's endangering the individual or others around them, really a trial of a medication like Abilify, which we've studied, or Risperdal, I think would make sense. So I think first, and I think a key point here is you want to identify what your target symptoms of treatment are, so then the family and the prescriber can be on the same page as you track change. Because no matter, where I'm teaching about medication use, I think it's key to understand when you're using something, and it sounds overly simple, but it's easy to get lost, that you want to really have at least a metric or something in your mind about what are we going to define as improvement. If we're treating anxiety, how does it manifest, and how are we going to see if it's changing to know if we should stay on the treatment or adjust the dose? So I would counsel that individual and anyone else that's trying to sort through what are we doing, define what the problems are, and try to come up with as many examples as you can and share it with your potential prescriber or your prescriber so then they can track it along with you to see if it's a helpful treatment.
Great, and there is actually more to that question. I'm going to read this, and I'm going to apologize here in advance, Dr. Erickson, because some of these medication names I'm going to stumble on, so you'll need to step in and correct my pronunciation. So in this particular case of of her 9-year-old son, she says that they have tried, when he was age 4, tried Ritalin, but had major side effects. Risperidone, which worked for a while, but aggression was getting worse. Tried some other things. She couldn't remember the names. Tried Abilify, which she had heard had a lot of success with children with Fragile X syndrome. And after that started at the lowest dose of arbaclofen in the trial, but she said she had to stop due to his brain adjusting to the highest dose, but she saw awesome results after each increase. She thought that working now with finding the right dose for Abilify might be the way to go, but when increased he had a muscle reaction, so they started Benadryl to counteract that, and then the doctor suggested Cogentin, C-O-G-E-N-T-I-N.
Yeah, Cogentin, the generic for that is benztropine. It's commonly used to treat antipsychotic-associated side effects such as muscle stiffening or twitching.
Okay. He had some, that seemed to have more negative behaviors, and again, made it hard for him to express himself. The doctor then suggested Tarax, or A-T-A-R-A-X.
Yeah, that's an antihistamine.
Okay, which he was hesitant to do to not having heard of any other families using that medication. So in the end here, and I'll sum this question up, although tried and a number of things that had some side effects, seemed not to be helping with his aggression and Her son is currently on no medication. He's showing some positives, has his appetite back, sticking tongue out. At first did major talking, but that has lessened. Still very hyper, very sensory sensitive, and a number of other things. Anyway, I share that with you. The rest of her question, I don't know if that would change your answer at all. She does sum this up or conclude this question by saying he's suddenly developed, again, intense aggressive behavior.
Well, what I would say is you really got to focus on that intense aggression, and if the first thing I would look at is what was the Risperdal dose. If Risperdal was dosed under 1.5 milligrams a day, we would consider trying it again at a higher dose in the range between even 2 and 3 milligrams a day. If that was already tried and didn't work, and if Abilify was tried at a fair dose, unless there were tolerability issues, the next medicine we would try for significant aggression would be Seroquel, Seroquel. The generic is quetiapine. It is in the atypical or newer generation antipsychotic class. It's available in both a time-release and an immediate-release form, and it would be the next thing to try. I think you really have to go through the list of newer generation antipsychotics. If you fail on Risperdal or Abilify, it doesn't mean that another one may work. And the list includes Seroquel, Zyprexa, and Geodon. Our most common, Zyprexa causes a lot of weight gain, so we would try Seroquel and then probably Geodon. The other interesting point is if the individual thought they had some success on R-baclofen, and there's probably lots of individuals like this out there, I think a trial of generic baclofen is definitely warranted, and that's what we're counseling our families on, that we are happy to try, especially if they thought they were having success on R-baclofen or STX-209.
Okay, thanks. Next question's about lithium. This individual wanted to know, adult son, recently started on lithium and having side effects of diarrhea and incontinence. Wondering if that's typical. Are there meds to combat the diarrhea, and what are the therapeutic levels?
I think those issues do occur with lithium at times. I don't think it's known to be a classic, really common reaction. Lithium is a drug with a significant toxicity profile. It's why it requires getting levels of it. A therapeutic range is normally in sort of the 0.8 to the low sort of 1.2 to 1.4 range. The real concerning things with lithium are thyroid dysfunction and potential kidney damage that can occur over time. In fact, when I teach about lithium, I say if you're on lithium long enough, it's pretty much going to burn out your thyroid gland and its function. The kidney potential damage tends to have later onset. It can also cause some issues with hydration and in dehydration, sometimes vomiting if your levels get too high. I would say if there's a lot of the incontinence issues and diarrhea, you could try, an over-the-counter anti-diarrheal treatment, but I probably wouldn't get much more aggressive in treating it than that, just because if it's requiring that much intervention, especially because of the concerns of, dehydration and your hydration status, it may not be the safest thing to potentially continue with.
Thank you for that answer. Here's a question. I'm interested in finding out more information about medications that have been found to be helpful in children with Fragile X syndrome who are high functioning. My son struggles with attention and anxiety and is currently taking sertraline and biphentin. How do I know when the dose is right? What are the signs of a dose that is too high, and what are the signs that a dose is too low? What is that second medication? Spell
that again real quick, Robbie.
biphentin. Not one you're familiar with, huh?
Biphentin.
Biphentin.
Biphentin. I've never heard of it.
Okay.
Trying to think if there's a spelling issue with it, or I'll look it up real quick too. Sertraline is Zoloft, which is a classic SSRI, which is frequently used to treat anxiety. No, but I'm not familiar. And the question was about
how do you
level?
know when the dose is right? What are the signs that the dose is too high? What are the signs that the dose is too low? And she describes her son as high functioning.
Well, I'll speak to sertraline. So we dose sertraline to effect, meaning, starting at, roughly, in somebody that's at least school age, 25 to 50 milligrams, dose up to 200 to 300 milligrams a day if we're seeing some continual improvement. There are no levels that you get with the medicine. And really, sometimes anxiety requires the highest doses to show effect. And so therefore, I think, getting up gradually even to 200 milligrams is what we would normally do. I think I'm figuring out. I think biphentin is in Canada is my problem.
Okay.
So, and it's used to treat ADHD. If you give me 1 second here, if I can figure out what the mechanism is really quick, I can comment on that. So, okay. I think it was just approved in, biphentin is a methylphenidate or a Ritalin derivative in a long-acting formulation. So that means we would dose that medication up to about 2 milligrams per kilogram of body weight as a max dose. Like all stimulant dosing, we recommend starting at a low dose and gradually increasing. So I think you could look at the individual's weight, and then the pound to kilogram conversion is 2.2 pounds per kilogram, and you could figure it out that way. But, with a lot of medicines, we start low, we make some adjustments. If it's doing absolutely nothing, we may move on. But if there's some improvement but not all the way there, I'm a big believer in trying to use something to a maximally effective dose before giving up on it. Because one thing what we try to avoid is having somebody on a medicine that's really not helping when they maybe could be doing better on a higher dose. So we like to probe those doses, and I think for the biphentin, we'd be looking at about, like I said, 2 milligrams per kilogram maximum.
So it's not always just the type of medication, but the dose and I would guess the frequency are very important variables.
Yep, dose and frequency are, I think, very important, and there's sort of different approaches to different drug classes, including on how long you look for effect. So a stimulant derivative, you're really going to see an effect within days. Something like sertraline or Zoloft, all of our research shows may not really show full effect for 3 to 4 to even 5 weeks at a dose. So I think that's very important, too, that people have a dialogue with their prescriber about when should we expect any change. It's not that everyone that takes sertraline, some people will take it and think they see improvement in a week or two, but really the research shows that the most common time period is a delayed onset, even out at a month, versus a stimulant where it's either working or it's not, and you know pretty quickly.
Okay. Let's go to the next question. This is, I think, a very good question and very specific. This writer says her son is 27 years old, was prescribed 20 milligrams of Paxil and 0.5 of Klonopin cut in half, in which one half is given in the morning and the other half in the afternoon for his anxiety. She is concerned about the Klonopin being habit-forming and wants to know how safe the Paxil is in the long term. He's been on both of these meds for a year now. He still, at times, has anxiety and behavioral issues.
First question I would ask is the Paxil dose been higher? And the reason I would ask that is, again, really, if you're having some response but still have room to improve, we would always suggest maximizing the dose of, relatively more safe medicines such as Paxil, which is an SSRI. Really, there's no data that long-term use of Paxil has significant negative adverse effects. As far as the Klonopin goes, it is a benzodiazepine class medication. It's a longer-acting benzodiazepine, which means it has less potential for abuse and dependence than shorter-acting ones such as Xanax. Klonopin, when taken chronically, day after day, like other medicines in its class, has some evidence that the effect may wear off in time, which then may lead to needing to take a higher dose. In a sense, your brain or body gets used to it. And so I think that is, of some concern. There's also some data that that class of medicines can have some dulling on cognitive functioning or dulling of thinking. And I will say this Klonopin dose is described as pretty low, but that's sort of a concern. But even with that said, the medicines such as Klonopin often help with anxiety a lot, but we would say really maximize your SSRI, which in this case is Paxil, to then minimize your need and minimize your dosing of something like Klonopin. Medicines like Klonopin are also somewhat difficult to come off of and take a great deal of time. Now, the good thing is this dose is pretty low, but we really suggest if someone's been chronically on a medicine such as Klonopin, Ativan, Xanax, or Valium, that they go off of it very slowly because you can have significant withdrawal symptoms such as worsening of anxiety, or worst case, if you stop from a very high dose, you can even have increased risk of having a seizure.
Thanks. Thank you. This next question is in regards to a 6-year-old boy who has moderate irritability, severe anxiety, moderate to severe anxiety, moderate to severe hyperactivity, moderate to severe attention deficit, and moderate obsessive-compulsive behavior. He is usually pleasant and soft-spoken, however, easily becoming anxious when confronted with new things, noises, and different tasks, very impulsive, not aware of dangers, short attention span, chews on clothing and non-food items all the time, and easily stuck on things, example, toys and speech, and is obsessed with playing water, but there's no sleeping disturbance or insomnia. Now, going back to your introduction here, she wanted to know, this writer, what's the effectiveness and safety for use of a high dose of folic acid? And I know you addressed that early on in your comments.
I would generally say there's not an evidence base that it's generally helpful, but I think it's safe. I have no aversion to individuals using it if they feel it's helpful. So that would be the counseling I would give. And it's the same counseling I give for a number of different vitamin and mineral supplements. I think the first thing is a safety concern. If there's not a safety concern, I think it's all right. I would tell people that there's not been published studies that say it's very helpful, but at the same time, if an individual would want to try it, it definitely is low risk, which I think makes it okay to give it a shot.
This writer then concludes by asking, well, then what about clonidine?
Well, clonidine is a medicine that probably has positive effects on hyperactivity, impulsivity. The downside of clonidine is it tends to be a little bit of sedating, so if given in the evening, it helps people sleep. I think this individual was sleeping okay. When given during the day, you just have to be careful with the dosing to not make someone sedated. There is a new form of clonidine that is time-release called Capvay. I think it's Kapvay, and it's given in the morning, and it tends to be less sedating because of that. The other thing with clonidine is you just have to be careful with the dosing because it can lower blood pressure a little bit. But among all the symptoms mentioned, I think the ADHD symptoms would improve the most. Maybe some relief in irritability and agitation, really less evidence of it helping with anxiety or obsessive-compulsive tendencies.
All right, thank you. Another writer here says, we have a young boy, age 5.5. He suffers from anxiety, OCD. His OCD interferes with the ability to stay on task and to play in a constructive way. Lots of self-injurious behavior and outbursts. This writer has done her own research and felt that he might benefit from an SSRI. Our pediatrician, however, she says, does not want to prescribe Zoloft as she feels this is not her field of expertise. However, the developmental pediatrician does, I guess in addition, the developmental pediatrician does not believe in medicating children at that age, and unfortunately the neurologist does not appear interested at all in this situation. My question is, what would be an appropriate dose of Zoloft for a child 5.5 with the above-mentioned symptoms, and can I ask one of the above-mentioned doctors to contact a Fragile X specialist regarding the Zoloft as a treatment for our son?
I think the last part there is absolutely. I mean, I think one role we really need to provide as Fragile X centers is building the capacity in the community where there's not that expertise to be helpful. So that's a case where I would always personally, and I think my colleagues across the Clinical and Research Consortium nationwide would be happy to take calls and discuss these issues. What I would say is if these symptoms are really impairing, that it really does warrant considering treatment. Dosing can be tricky. There's a couple of ways to go here. One is Zoloft or sertraline, which is the generic, is available in a liquid formulation, which allows very tight dose control and allows you to start at a low dose. I think a goal dose for this individual would be to get up to even 12.5 to 25, kind of a maximum of 50 milligrams a day. We would try to start as low as even 5 milligrams for a week and then get up to 10 or 12.5 milligrams depending on if you're splitting pills or taking liquid. I'd hold there for 3 or 4 weeks, see how it's going, and then go up in the smallest increments we could. And again, it depends on if you can get a liquid or a pill, but target range of 12.5 to 37.5, maybe a maximum of 50 milligrams. But I would try to get up to 12.5 and then hold there for a month and get a read on it. But yeah, I mean, the thing is, there's not going to be a real comfort level in a lot of communities of providers in treating 5.5-year-olds with Zoloft. I will say, though, I mean, there is a lot of evidence of use of SSRIs in younger children. Now, it's not specific to Fragile X, but specific to mood and anxiety disorders primarily. So, but I think we do have to share that expertise to build the capacity, and to what end I can do that, I'm happy to.
Okay. So, Dr. Erickson, I'm going to focus again on some more generic general questions because I think they are probably of the greatest interest to the greatest number of listeners here. I think this is a great question. What would be a drug one could give in an individual with Fragile X syndrome only as needed for times when there is a full-blown anxiety meltdown, as needed? Is there such a thing?
That's a great question. I get presented that question a lot. I think there are a couple of ways to go. This is where, we talked about the benzodiazepines, Klonopin, Ativan, Valium, Xanax, where maybe it's not always the best option for chronic daily dosing, but I think they really have a stronger position as needed or given prior to situations that are thought to be anxiety-provoking or during a major meltdown or a panic-like situation. So to that end, something like Ativan, anywhere from 0.5 to 1 to 2 milligrams, depending on age and size of the individual, can be quite helpful and fast-acting. And we will provide scripts for, several pills to be used in those as-needed situations, and really can provide some relief. I just, work with a family in clinic recently, and it's not the first case where, an individual has field trips or places to go, and they're just really paralyzed by anxiety, and it's concerning to the individual and the family. And so we'll try something like a benzodiazepine class medicine prior to an event if we can predict it, or in the throes of a major meltdown to have a fast-acting anxiolytic and potentially mildly sedating effect. And the goal is never to sedate, but sometimes when it's really a difficult situation, a mild degree of sedation can sometimes provide a measure of safety too, and I think the benzodiazepines are a good option. The second class we try are antipsychotic medications, so an additional dose of Risperdal, an additional dose of Abilify, an older antipsychotic like low dose of Haldol or even low dose of Thorazine, I think, are other options. The Haldol and Thorazine would sort of be third or fourth line if other things didn't work. But we would probably try one of the benzodiazepines as needed as a first approach.
Okay, this next question, very interesting, kind of looking into the future here a bit. If and when a GABA B receptor agonist drug and an mGlu-R5 agonist drug, antagonist drug are approved for treatment of Fragile X syndrome, is it likely that both could be used together?
That's a great question, both clinically and scientifically, and it's something else I think about because, it's sort of the idea of coming at something from multiple angles, and I don't think there's any reason medically or neurochemically why you couldn't take both. So I think if multiple things become available, certainly they could be combined. It also begs the question of, is the ultimate best answer a combination approach? Now the problem is that's really hard to research and study because how do you bring together these different molecules, these different drugs from different companies? One approach we have in our research is to work with medicines that don't just affect one neurotransmitter at once, that have multiple effects as a single drug, and that's what we do with our study of acamprosate now. But I think to answer the question, yes, I think drugs could synergistically potentially be used together, and I think as a field we have to pursue co-treatment in both animal and human study or use of a single drug that affects multiple neurotransmitters in the brain because it may well be more complicated than just hitting a single receptor to have an effective treatment.
Speaking of acamprosate, this writer says, will you please discuss the risks and benefits for children with Fragile X syndrome?
Regarding use of acamprosate?
Yes.
So first the risk. So it's FDA approved for alcoholism. The most common side effects it's had in clinical trials around the world in adolescents and adults and in our limited trial experience with children are gastrointestinal effects, so maybe a 10% rate of loosening of bowel movements or upset stomach. It's not liver metabolized, so it doesn't interact with other drugs. It's just excreted in the urine, so if someone has kidney dysfunction, it's not necessarily indicated to be taken. The biggest barrier to our acamprosate study is the need to swallow the pills because they're enteric-coated or they're meant to be swallowed, and that can be a challenge because they're a little bit larger. They're hard to cut up, and if you cut them up, you may increase your risk of having some of the upset stomach. The benefits in our published data with acamprosate are improvements in communication and reductions in hyperactivity and reduction in social withdrawal or improved social skills. But I have to say we're relatively early on in the study. And right now, though, we're ramping up to do a large placebo-controlled study with Liz Berry-Kravis as a partner at Rush in Chicago. So that'll really be sort of our definitive study. But we're hopeful that it has a good tolerability profile, meaning it's already approved for something else. It doesn't have any major toxicities, like the thyroid or kidney problems or abnormal movement or weight gain or anything like that. So in that sense, with good tolerability and some potential, we're going to try to pursue it as much as we can.
Great. Okay. So speaking of drugs that are already available for something else, and you did mention this briefly in your introduction, but if you might just say a few more things about minocycline The writer wants to know, is it available for children with Fragile X syndrome outside of a clinical trial?
Sure it is. It can be prescribed by anybody that can prescribe medications. It's most commonly used in this country, at least in the United States, to treat acne. It is readily available. I think the caveats or concerns are in young children, it's been shown to cause graying of teeth during early tooth development. And I think one other concern that was pointed out in an early clinical trial conducted in Canada is that there's some risk of sort of a drug-induced autoimmune lupus-like condition. So when we do prescribe it, if families are requesting it, we get blood work to look for that autoimmune reaction. And I generally don't prescribe it in very young children still with their sort of child developing teeth. But yeah, it's available, sort of off the shelf, can be prescribed. And I think Rondi Hagerman has done a really solid clinical trial of it with a published result. I wouldn't say it's an overly positive published result, but again, it's used by thousands and thousands of people, and I think a number of different prescribers are comfortable with it because of the acne indication.
Thanks. This writer has a 12-year-old son with Fragile X syndrome. She says that on 5 occasions, apparently in school, he has, quote-unquote, totally lost it. Starts with a look on his face. He will just scream. And once at the school, he did destroy the classroom, threw scissors at the teacher, scratched the vice principal, and was subsequently suspended because he was violent. He currently takes minocycline, 100 milligrams 2 times a day. INTUNIV, 3 milligrams. Is there a medication that he can use as needed? Again, the as needed question. Or should he be on something to help him take the edge off? He has been on numerous ADHD-type medications, also Paxil and Abilify, without success.
The next thing we would try in that scenario, if you have sort of a Paxil Abilify failure on minocycline and Intunib is long-acting 10X or long-acting guanfacine that's FDA approved to treat ADHD. I would try Risperdal, really because I think it has a really solid evidence base for use in people with developmental delay and developmental disorders, that it helps with irritability or major outbursts. And I think potentially a maintenance dose of that would be a good option. If you needed to go the as-needed route, like I said, benzodiazepine, Ativan, Klonopin could be options. Risperdal as needed, we definitely use that some. Sometimes we'll have people that are taking some amount of Risperdal every day to kind of maintenance, reduce agitation, and then also can have an as-needed booster dose if they're having a particularly rough experience.
Thanks. Here's a very interesting question. What is the youngest age that we should start thinking about using medication? My son is 11 months old right now.
Well, first of all, I think if you're using medication to treat interfering behaviors and symptoms, you have to have that degree of interference. Meaning, if you're hyperactive and you're inattentive and you're 18 months old or 2 years old or 3 years old, and it's not really impairing you, I think you kind of go with it. But if you're then in kindergarten and your ability to potentially learn and interact with your peers is severely impaired because of symptoms, whether it's anxiety or ADHD symptoms or aggression or whatever, then I think you have to consider treating. I get these questions all the time about the very young children, and they normally focus more on the targeted treatments, and I can completely understand that as a parent. I mean, if I had a child that I thought that there were targeted treatments that could positively alter the course of their life, I would certainly want to treat as early as is absolutely possible. So that really resonates with any parent. I think with that said, combined with the fact that we are not in a state yet, hopefully, where there are FDA-approved medications specifically for Fragile X, that I am left advising families like that to generally hold tight, and if you want to do something that is definitely has a demonstrated safety profile. That could be a vitamin supplement, folic acid. There's a supplement called curcumin, which some families ask us about giving to their really young children, and I feel that I can at least say it's relatively quite safe. I get asked frequently about giving a camprosate to very young children, which is difficult for me because, we do all these trials and research, and we know all about the medicine, and we're very hopeful about it, but I can't tell you what it's going to do in an 11-month-old child. I just can't. So I think because of that, we tend to wait at least into toddlerhood in our program, even for the targeted treatments or the novel treatments, the safer ones. But certainly you want to avoid things that have a more significant toxicity profile by all means, things like lithium and even the antipsychotics and the benzodiazepines we talked about in really young children. So, my hope has always been if we can get some positive placebo-controlled trials of these targeted treatments in older age individuals, that the trials will come into the younger age range. I think that's the goal. That's where we're going to go. But we gotta get a positive result out there, and then move younger to really offer hope and options for people like the family with the 11-month-old. Because that's our goal. I mean, that's why I'm in this business. It's to bring the best treatments we can as early as possible, and it's a challenge, but I think we're getting there.
Okay. Well, I think with the number of questions, we could probably go another 3 or 4 hours, so we're not going to be able to do that. So we'll just keep moving along at the clip that we're doing so, and I appreciate, Dr. Erickson, your answers so far have been very, very helpful and enlightening. So let's just continue on here for a bit. So I think what this next person is asking is, have there been studies with medicines and a gluten and casein-free diet? I don't think those are two separate questions, but one, if the diet and the medicines studied together. But you think you could address that?
Yeah, there's never been a study of medication plus diet in any form of developmental disability that I know of, and there have never been any specific gluten casein-free diet studies in Fragile X. There's very limited study of gluten casein-free diet in autism spectrum disorders of unknown cause, and there's never really been a published or presented positive clinical trial or research result from dietary interventions. What I counsel families when we talk about diet is there's no specific harm in going gluten casein-free as long as your child otherwise is getting appropriate vitamins and minerals, so hopefully, at least a multivitamin. The big challenge is just executing the diet, and we sometimes see behavioral worsening when families try to go to specific restrictive diets, and sometimes that may not be worth it if there's not an evidence base. If families are worried their child has gluten or casein sensitivity, they can certainly get testing for it, and we would recommend a normal workup for gluten or casein sensitivity, which is most frequently blood testing if that concern exists. It's sort of like, why go on the diet when you could know if you specifically needed it, that kind of approach. And I get asked that in autism all the time, and that's what we counsel families to do.
Okay, great, thanks. So this person really would like you to comment on the effectiveness of Abilify versus Risperidone to deal with excess aggressiveness and physical issues in a 40-year-old man with Fragile X syndrome.
So our group published the only clinical trial of a newer generation antipsychotic in Fragile X, and it was a 12-person open label, meaning everybody got the drug, so the result is somewhat always going to be over positively reported. But at any rate, in that study, we saw upwards of 75 to 80% of individuals showing a positive response to Abilify, marked by reduction in aggression and irritability. There's never been a systematic study of Risperidone specifically in Fragile X, but there have been a multitude of studies in idiopathic autism spectrum disorders leading to its FDA approval. In some ways, it's a bit of a flip of the coin. Risperdal is known to probably have more associated weight gain than Abilify. I think you try one, and if it's not helpful in a therapeutic dose range, you go to the other. Some of the research we're trying to do is develop predictive profiles of who would do better on one or the other, but we're still not there yet, so I think they remain somewhat interchangeable. I think the lore in Fragile X is that Abilify is maybe better than Risperdal, but I certainly can't prove that.
Thanks. Dr. Erickson, this writer wants to know if you think SSRIs can trigger aggressive episodes. After an increase in Prozac, this writer's son became prone to these aggressive episodes, and after stopping Prozac, they saw improvement.
I think that's definitely possible. Again, like in a lot of my answers, not SSRIs are very commonly used. I think their use is appropriate, but there's not a large evidence base specifically in Fragile X syndrome. In autism of unknown cause, not associated with Fragile X, we see that SSRIs can exacerbate agitation in maybe 20% of cases, especially in youth, and especially prior to puberty. So I think that is not out of the realm of possibility. So we recommend, generally, and when I got the Zoloft question earlier, sort of start at a low dose, get up to a little bit of a higher dose after a week or two, maintain there for a month. And we always counsel families on starting SSRIs that it could rarely result in, we would say, kind of lability or getting more agitated or up and down, and you just have to monitor for that. So I think it is possible, and if it happens, either lowering of the dose or removal of the medicine is at times indicated. But I don't want that to scare people away from using the medicines for anxiety, because I still think they're good medicines, but there is that risk, and I think, at least in that case, it's a distinct possibility.
This next writer was part of the STX-209, or baclofen open-label study. Their child has never been aggressive. His Fragile X syndrome is manifested primarily in anxiety and not being able to go outside, I believe, or wanting to go, but not being able to get but then wanting to go out, but not being able to get out of a car. What class of medication might help him?
It's a great question. I see a number of patients in the parking garage because anxiety to the point of not being able to come out of the car, I think, occurs more frequently than we may realize. I think, again, it's anxiety, and we would say giving an SSRI a chance makes a lot of sense. We also sometimes use a medicine called Remeron. The generic is mirtazapine. It has anxiolytic qualities. It also helps sleep. I think that is a potential good option. And then if it's a rare situation, as needed medicines, but this sounds more to me like a chronic significant anxiety, and when we would sort of run through at least a couple SSRIs before giving up on that class, then move on potentially to Remeron. The buspirone or Buspar medicine I mentioned in my initial slide is a really pretty benign medicine that may work, it may not, but it doesn't have a lot of side effects. So that's kind of the litany or list we would go through. If there's also aggression or self-injury and significant tantrums associated with it, I think, somewhat stronger medicines like Abilify or Risperdal would maybe take a little bit of an edge off and improve transitions too, but wouldn't be really the first option.
Here's another family whose son was a part of the baclofen extension. 10-year-old boy who someone has recommended racemic baclofen to decrease significant behavior change. The writer asked their doctor, but the doctor said she is not familiar with this. What is the right dosage, and how long would he need to take racemic baclofen?
Well, what I do dose conversion-wise is I ask individuals what dose of STX-209 or baclofen they were on, And then, so let's say somebody's on 10 milligrams of SPX-209. The conversion to generic off-the-shelf racemic baclofen would be 20 milligrams, because in a sense, the off-the-shelf racemic baclofen is half our baclofen and half sort of inactive form. So that's how we do dose conversion. We take the SPX-209 total daily dose, multiply it by 2, and then divide it out either 2 or 3 times a day. And we've worked with some families on a titration schedule where they lower their SPX-209 and then add baclofen in gradually. If somebody's come completely off SPX-209 and wants to go on an equivalent, we would kind of upward adjust to that dose over a several-week period and not just introduce it all at sort of the peak dose. And that's what we do. And you know, it makes sense to try that as a first option if families think that their child was really doing quite well with SPX-209 in the extension.
By the way, Dr. Erickson, the Foundation recently updated its frequently asked questions section on the SPX-209 end of the extension trial, and there are some general or generic observations and commentary on racemic baclofen, so our listeners might find that helpful also. Here's a question: is Zoloft safe for a 3.5-year-old with Fragile X syndrome? This child has a lot of difficulty with just not being well adjusted, hates being redirected, hits himself, and throws fits all day long.
Well, as the evening goes on, the questions get harder, which is I don't know if that's good or not. But you know, if you have a 3.5-year-old that's having really significant behaviors, it's tricky. I mean, I most commonly treat that young when I'm treating aggression and self-injury and severe tantrums, where it's clear that the child may hurt themselves, they may hurt a peer, they may hurt a sibling. They are unable to participate in early intervention services or developmental preschool because their behavior is so really significantly impairing, and they can't get all they would want out of therapies because they're hitting or those kind of things. Or they're just so hyperactive and impulsive and they can't slow down even to learn. And in the just hyperactive sense, there is data that stimulant medications are really pretty well studied down to age 3. There's data that Risperdal is well studied down to age 3 for treating more severe tantrums, aggression, and self-injury. You know, I have a little more confidence using those medications in that age range than in SSRI, but you certainly can argue with that position, and you can really make the argument with it from the idea of, well, hey, if anxiety is really driving this, then shouldn't you go with an anxiety-relieving medicine first? And that's hard to argue with, but I have to say that the risk of getting a little wound up or labile and up and down with the SSRIs in really young children is not well explored. So in the underage 5 set, I think it's a challenge. And, you know, we all have prescribing differences. For instance, I think, you know, Rondi Hagerman, who I have a tremendous amount of respect for and I think has done tremendous work to move the field forward, is probably, I would think, the most comfortable person in the field using SSRIs in really young children, and she has research focused on it. So you're going to get some prescribing differences. That's a little bit of my bias. But again, it's sort of what's that underlying thing? Are you really just getting at hyperactivity in that child? Is it becoming really significant aggression, or do we think it's all anxiety? Sort of make your call and then follow that with your med choice. And that's the dialogue I would have with the family.
Good, thanks. You know, we've got just a handful of remaining questions. I would ask our listeners that we're not going to be able to accept any new questions. So let's go ahead and see if we can wrap these up here. And here's a very unique one. We were told that we were violating our 37-year-old son's human rights by giving him an additional dose of Adderall to help him cope with boarding his van for work in the late afternoon. They want to use a behavior modification plan in place of medication. Any thoughts on that?
That's a tough question. I do want to say one thing, because this brings up the concept of guardianship. And, as someone that prescribes and works with adults, I think the one key thing is to address the guardianship question at the appropriate time, so you have a guardian in place that can make appropriate decisions. Because I have to tell you, we have 30-plus-year-olds that come into clinic that are their own guardian, and it's not appropriate, and then these situations almost can't be figured out. So aside from that, we run into these issues as far as providers, whether it's a group home or a day program or respite, and sort of the letter of the law of how medicines have to be administered, and how that may be different if a child was just, living at home all the time, and then their guardian really has essentially more control. I do think the concept of Adderall as an additional dose for something like that is a little out of the ordinary, just in the sense that I would expect the Adderall would maybe help with hyperactivity. So if that was the issue and someone just needed to kind of slow down to be able to take a breath and do something, that maybe makes sense. If it's used infrequently, I think that would be okay. If it just needs to have a dose adjustment to where they need like an afternoon Adderall dose to calm to the point where they could do something like this, I think that's fine. But you know where the provider's coming from too, that I often see that providers of services are under governmental and other pressures to develop medication reduction plans, which is good and bad. But I think that family really just should talk with their prescriber, frankly, and not necessarily allow themselves to be told that this is some sort of violation, and they should have a dialogue and determine the best course of treatment, whether it be a behavioral intervention, whether it be a med adjustment, or whether it be both at the same time, and go with it, because it certainly doesn't seem to me like a scenario where there's a rights violation per se, at least with the limited information.
Okay. All right, 3 more questions here, Dr. Erickson. High anxiety. This writer says her son is 15 years old. He's verbal, but he has high anxiety. The anxiety is much worse during the school year. They see more anger and aggression. Things are better during the summer, but he still has anxiety. Do people ever use certain medications during the school year and then take them off during the summer?
Well, they classically do with stimulants because they're in and out of your system, things like Ritalin and Adderall derivatives. It's trickier with medicines for anxiety because, as I said earlier, especially the SSRIs build up in your system. They have some secondary effects on the brain that promote additional sort of brain connections and things that help treat anxiety. And the problem is if you're sort of ramping on and off, you may lose some of those effects. So if somebody's on Paxil, Prozac, Zoloft, Celexa, Lexapro, any of the SSRIs, we pretty much say, stay the course through the summer because coming on and off is really not the best. If you're getting relief from Adderall or Ritalin and it's helping with focus and impulsivity, fine to take drug holidays in the summer. No big deal. Start it back. So I think it depends. So if it is anxiety and it's being treated with an SSRI, I think you really need to stay the course. Even though the need is less in the summer, I think keeping it in the system and keeping up those effects just enables it to be that much more effective when the new school year rolls around.
Okay. I think it's probably appropriate to maybe wrap things up here with a question about acamprosate. This person's looking for information on benefits, side effects, and dosing. 7-year-old child with high anxiety, self-injury, and aggression. The parents recently asked the neurologist about acamprosate, but he was unwilling to prescribe it at this time due to a shortage of safety information. Instead, he prescribed sertraline, which we are starting today. Do you have a preference? Well,
I mean, my preference would be if I'm just treating anxiety and somebody's never been on an SSRI, by all means, feel free to try sertraline or Zoloft first. A lot of our research with the camprosate is primarily been as an add-on treatment. So individuals that still have room to improve, still have room to reduce their anxiety, still have communication impairment, still have some social deficits. And then we've seen that camprosate sort of boost skills beyond what individuals are already getting. As far as dosing, our average dosing in our research to date has been 3 pills a day, which is 999 milligrams a day. And I think in that age range, we would start somebody on 1 pill in the morning for a week, and then every week or 2 weeks increase by potentially 1 pill up to 3 times a day, and monitor for the loose bowel movements, upset stomach that we talked about, monitor for any behavioral changes when you're on a behavioral medicine, and kind of go from there and see if it helps those skill sets, if it reduces anxiety, if it has a calming effect, if it improves communication. And the thing that I still don't know the answer to with it, and we'll find out in time, is if it is working, is it working because it lowers anxiety and then other things improve, like social behavior and attention and communication, or is it having sort of unique effects in multiple areas? We don't know the answer. As far as safety data in youth, our research in Fragile X and in autism is the only study of a camprosate that I know that's published in people younger than age 16 in the world. So I think it's fair to say that, there's not a huge safety database for it, but it's also fair to say that it's not liver metabolized, doesn't interact with any other drugs, doesn't have any real fear or concerning, provoking adverse effects that have been shown in thousands and thousands of people, adolescents and adults treated around the world. So yeah, I mean, it's there's not a huge safety base in children, but there's also not an inclination that it has a lot of toxicity. So that's where I would go. But I think it's that scenario, it's fine to even start with the sertraline and see how much it may help, and then if there's still room to improve, consider that as something more novel like the camprosate on.
So there's going to be a few writers who did not get their questions answered. Sometimes it's because I think you already answered them in other ways. There were a few more questions, for example, about folic acid. But those who did not get their answers that they were looking for tonight, I apologize. Dr. Erickson did provide his email address in his last slide and graciously offered to respond to those questions. But Dr. Erickson, I'm going to ask you a last question, because I'm going to ask you the one that we often get here at the Foundation when somebody is relatively newly diagnosed and reaching out to the National Fragile X Foundation for some guidance. And that is, what should they be thinking about in regards to just the simple question of medication versus no medication at all? Those people who want to see if they can go through go as long as possible, or maybe throughout the child's entire life without using any medication, or those who are just trying to figure out what would tell me that I need to begin talking to my doctor about medication. How would you answer that?
I think you talk to your doctor about potential medication if there are behaviors or symptoms that are concerning and interfering. And as I've tried to emphasize, that can be interfering in school situations, it can be interfering in therapy situations, it can be interfering in the home, it can interfere with the ability to interact with others. If you feel that your child, if they had relief from anything we've talked about tonight, and it would make it easier for them to make more gains, to interact more, if you feel that there are impairing things, anxiety, inattention, hyperactivity, agitation, whatever it may be, if it's impairing, and if you've tried behavioral interventions, you've done what you can service-wise, you've approached things in non-medication ways, and hopefully you've had some degree of success, but there's still some room to improve, that's where I think medication can have a real place, and at least to be discussed. To discuss the risks and the benefits, to discuss if the benefits were to occur, what would they be, and then how are we going to track change and really think about if something's working or not, so we know if it's appropriate to continue. I think that's the dialogue to have. You know, and I obviously make a living. I prescribe a lot of medication. I do a lot of medication-associated research. But truly, the goal is always the least amount of medication at the lowest doses. And you have to believe that. And whether you're somebody like me or somebody that doesn't prescribe much medicine in Fragile X, regardless, that's the goal. And so that means that you want to do all you can with other services and therapies to make as many gains and limit as many interfering symptoms and behaviors as possible. And then if there's still some there that you need to boost, that's where I think medicine can really be part of the dialogue.
Dr. Erickson, this has been extremely helpful, very enlightening, and my guess is that our listeners have found it that way. I know that people will still have questions about existing medications, their hopes for new medications, and I'm sure we're going to be reaching out to you again for your wonderful insights. So thank you very much. The National Fragile X Foundation is honored to have you be part of this webinar tonight. Special thanks again to Warren Global Conferencing, which helps make all of this possible. And thank you all of your listeners for your great questions, and we look forward to having you on our next webinar. So good night, everyone. And this concludes tonight's presentation.